Thank you very much for allowing me to present at this year's event. And I apologise for Rick once again that I mistimed my holiday and my commitment to your course. But today's topic's going to be on sinus surgery, who, when and why. And I think if everyone's heard me speak, this is very much a topic I like to talk about, because when I was a trainee, there was very little guidance in my mind as to exactly who needs surgery and when. So we're going to go through some of the background of why we operate and then discuss when and how to apply sinus surgery. Now, the first thing that's very important, I think, is that we need to define what are we treating. Here is a good example of a patient in where rhinitis, where the inflammation is of the nasal passage, is very different from sinus disease. But you'd be surprised how many times in clinical practice this is not so clear. So rhinitis to me is a disorder of the nasal airway. It's often associated with reactive vascular changes, congestion, glandular hypertrophy. And many people get intermittent rhinitis, and a recent study of ours showed that most people who believe they're getting a recurrent acute sinus disease actually don't get sinus disease. They simply are getting recurrent rhinitis episodes because we actually sat down and scanned and examined them during the acute event. This is an example of the glandular hypertrophy, another feature that we classically see in rhinitis. Now, sinus disease differs greatly though, because sinus disease is characterized by mucosal inflammation, which often presents as polypoid change. Often the nasal airway is not nearly as congested as the rhinitis sufferer. There is a degree of secondary mucociliary dysfunction, and because of all of that, we get then recurrent microbial colonization. There are still two schools of thought about why we get sinus disease, and we're not going to go into that in this talk, but the idea that simply the microflora is the cause of chronic sinus disease, I think, is flawed. Inherent to most people who get chronic disease, there's something else going on other than just simply an infective or contamination phenomenon. One thing we do know for sure, though, is that our understanding of sinus disease has differed greatly in the past 25 years. A common theme, though, is that chronic rhinosinusitis has very strong pro-inflammatory origins. And there's very few people like this guy here who will rock up to a GP even these days and be told he has some sort of chronic infection. We understand that patients have nasal polyposis and lower airway inflammation such as asthma. They have an inflammatory reaction in their airway. I still don't think we understand why this has driven this inflammatory response, but what it is, and it's not just a simple infection, nor is it just simply an inflammatory reaction to something in your sinuses. But unbelievably, if you look back at the literature in the pre-1980s era, everything was about infection and blockage, like we're all boxers. Respiratory physicians were a little bit ahead of us, and they understood that a lot of chronic airway inflammation was inflammatory, and I guess during that time period we acknowledged that people that had gross polyps had inflammatory dysfunction. But really in the last 15 or 20 years, there's been a lot of shift to show that while infection and obstructive phenomenon does cause some sinus disease, a lot of what we see, with or without polyps, is actually an inflammatory reaction or a disordered inflammatory reaction. Now, when you read medical textbooks, which were written 20 years ago, it's not to say that mucociliary function's not important. You have to have mucociliary clearance. Cilia has to beat. It moves mucus around, and if you block this system, you will get sinus dysfunction. But what you won't get is simply just the chronic rhinosinusitis we see commonly in our community. We have examples of where mucociliary clearance stops. We get mucocil formation. In reverse, we get maxillary and sinus atelectasis. But simply, you don't get chronic sinusitis just by having mucociliary dysfunction, because it's not the major defect in CRS. Now, once again, it's not our current understanding of sinus disease is not to discredit osteal occlusion. Osteal occlusion is still an important process, but it's limited. And so this is a person who has osteal occlusion. They have an isolated issue with their OMC on one side affecting either that sinus only or dependent sinuses that drain through that pathway. They don't have disease in the other sinuses. They don't have a lower airway disease. It's an isolated process. And some of the early sinus surgery courses did focus a lot on OMC. So this is a slide from David Kennedy's first course. It talked about the osteomeatal obstruction, because if you applied surgery to these patients, you literally cured them, and that was it. Nothing more required, because inherently by doing the surgery, you broke the pathogenic process that was driving the condition. And there are reasons why some patients need surgery. You simply can't just give them lots and lots of antibiotics and steroid and they will eventually get better. Because in the sinuses, with chronic inflammation comes basement membrane thickening on the left there, subepithelial fibrosis, and even squamous metaplasia. And once some of these events occur, they're simply just not sensitive to ongoing medical therapy. So corticosteroids and antibiotics, you might only reach a degree of reversibility, and then surgically you may have to intervene on simple osteal occlusion. But you know what? None of that is common CRS, nor is it certainly CRS with polyps. These patients here are the sort of patients that we commonly see in practice. Now, I always told my colleagues, oh no, but simple maxillary sinus or sphenoid sinus disease is very common. I'm not sure if that's actually true. What I think is common is patients who present with patchy mucosal disease. This is very common. Sometimes it's associated with polyps. Polypoid change is common in the community. It doesn't have to be as extensive as this person, but really there's often no culturable bacteria or even detected on biofilms. And this person here, in my mind, has absolutely nothing to do with the previous example I gave you, except for the fact that the disease process occupies the same anatomical space. And these patients don't have ventilation problems. My patients are clever. They look at their sinus cavity and they can realize there's lots of normal sinus mucosa. And it was not ignored by rhinologists. They acknowledged that there was persistent localized inflammation. But this is a process that's been a little bit forgotten, I think, in some of the algorithms that are taught. So if we have a look at this person here, you can see that this person's got osteomeatal occlusion and has normal sinus mucosa. So it's not a ventilatory problem. We weren't the first to sort of acknowledge this. This is a study by Rick Chander and his group that looked at the relationship of osteomeatal occlusion to obstruction in either the dependent sinuses, which are the maxillary, the anterior ethmoid, and the frontal, and they looked at whether or not these sinuses on radiology were affected based on whether or not you had osteomeatal occlusion. And they really only showed some relationship with CRS without polyps. CRS with polyps showed absolutely no relationship between osteomeatal occlusion and disease in the dependent sinus. Ray Sachs and I did a similar study where we did exactly the same study where we took patients requiring sinus surgery and we defined them as having eosinophilia, and we looked back on whether or not the OMC was occluded and there was associated disease in those sinuses. We had 70 patients in which we looked at whether or not they were eosinophilic, and we broke them into these eosinophilic, non-eosinophilic groups. And here is the summary slide, really to point out here that the only relationship between osteomeatal occlusion and disease in the dependent sinuses was if you had non-eosinophilic CRS, did you demonstrate an association between OMC and the maxillary sinus only. Really everything else demonstrated no relationship between whether or not there was osteomeatal occlusion. Now, where does that place us then on the scheme of disease? Well, sure, we do have examples of simple infection obstruction. This is like this person here. This is the unilateral OMC, maxillary sinus. There's a whole lot of minimal techniques you can do here. This is why Specialists before us got away with simple antral washout because they treated some of these patients, like this person here, and got a great response. But there are lots of other simple surgical cases: fungal ball, mucoceles, antroquinal polyp, simple nasal polyp. All these things required a simple surgical intervention. There is a condition, allergic fungal rhinosinusitis, whether this is a true clearance of antigen problem, but this sort of sits somewhere in between, so AFS. But it's this end of the spectrum, nasal polyps, which is really all about eosinophilic airway inflammation or other disordered inflammatory responses, which may not be eosinophilic, there are neutrophilic versions, but these are broader inflammatory airway disorders. And the techniques we use here is wide sinus surgery to create a cavity where we can remove inflammatory products and give topical access to therapy. Now, the first thing I think we need to do when we talk about when to apply sinus surgery is we need to sort of say, well, what are we dealing with? You know, we acknowledge surgically, or I should say endoscopically, that patients differ greatly. On the left, we have a patient with nasal polyps. On the right, someone with some purulent secretions. They are different conditions going on. And we need to separate these. And this is where I really strongly promote the idea that we should be asking our pathologists to give us some more information. And we use a routine pathology report that gives us information about what type of inflammation is that's going on in the sinuses. The information comes back as a simple report like this. It tells us about whether there's eosinophilic mucin, Charcot-Leyden crystals, or evidence of eosinophil activation, basement membrane thickening and remodeling changes which portend a poor outcome, degree of eosinophilia, and maybe even the lack of eosinophilia and evidence of neutrophilic inflammation. These are the sort of things that we use to help guide our treatment. Our treatment paradigm then still involves eradicating bacteria, but we don't see them as being the primary cause. We see them as being a colonizer. We then create a sinus cavity for these patients with inflammatory disease that gives them a simple cavity that they can look after. They replace mucociliary clearance, which is dysfunctional, using an irrigation bottle. This is how we overcome the mucociliary loss that occurs during the inflammation. And we treat the process locally, but not with simple nasal sprays. And I guess for me, this is a huge shift. It's very difficult as a surgeon. You get a lot of satisfaction of removing a big polyp like this one here. But you have to remember, while we remove this, and this was done routinely as the intervention many years ago, it actually doesn't do anything to the underlying condition. Just removing a polyp. What we're trying to achieve is setting the patient up so that we can actually control the process that created the polyp. And I think that's what's important. So the philosophy, especially for polypoid or inflammatory CRS, is acknowledging that it's an inflammatory disorder. We don't control it surgically or medically. You don't go from medical onto surgical. So we don't place one above the other. It's all about shifting someone from a disease process that's in the sinus cavity, where really the only way you can get anti-inflammatory medicine into your sinus cavity is through systemic or oral means before surgery. And so surgery is a way in which you can shift someone from systemic treatment to local treatment. And it's acknowledging here that really the medical therapy we give to patients into the sinus cavity is really dependent on getting it there through the blood prior to surgery. And certainly simple nasal sprays are not sinus treatment. So how do we effectively deliver topical therapy into the sinuses? It's all about surgical state and device, and many of you might have heard me speak about this, so I'll go through this quickly. But with lots of studies looking at, such as this early one, which we looked at 3 different types of delivery and 3 different surgical states. And this is just to reinforce this idea that if you look into the maxillary sinus here, this is a camera in the sinus cavity. There was no spray getting in. An irrigation bottle gets a little bit of fluid into the sinus cavity. You can see the natural ostium there. Neti pots don't really work down the ipsilateral side. The contralateral flow and the head position of neti pots helps to get some fluid in there. But it's really only when you do sinus surgery do you change the ability for topical therapies to get in here. This is now looking with a simple spray. We ran out of the dye spray, trying to get it into the sinus cavity. And this is what an irrigation bottle does in terms of delivery. Now, if you said to me, where's the evidence for all of this? Well, if you look at randomized controlled trials of patients with corticosteroids versus placebo in CRS, you'll have a look here. You'll notice that although the overall effect favors steroids, there's a lot of heterogeneity here, with many studies demonstrating no effect from the use of corticosteroids. And one of the ways that you can explain this heterogeneity is that if you look at studies in which the randomized controlled trial was done on patients who'd had previous sinus surgery versus those who hadn't, there was a much greater effect of the steroid in patients who'd had sinus surgery compared to those who didn't. And so one of the ways you can explain the heterogeneity of response, because many studies failed to demonstrate much benefit from using a simple spray, but the ones who did were done in patients where there was prior sinus surgery. So the idea then, some people walk away from that message saying, so I just need to use more intranasal corticosteroid spray? No, because this is where intranasal corticosteroid sprays go. This is where you want the medicine to go. You want it to go into the sinus cavity. So we then use different devices. There's a lot of different devices that have been promoted. Pulse nebulizers, atomizers, bidirectional flows, neti pots, squeeze bottles, and even higher volume nebulizers, which do require a device, and that's why they're not so popular. But the one thing that's true here, and this is me, spraying my nose late at night with methylene blue to prove a point here, that methylene blue, when sprayed via a spray bottle, it demonstrates where the distribution is, and it's essentially the nasal cavity, and only a tiny bit even gets to the middle turbinate head. What it isn't, it's not a sinus treatment. Now, there's a lot of information now on the impact of delivery device and surgical state. This is a great review article that came out in International Forum a couple of years ago that goes through all of this, and it's really worth it. But one thing that's true for me, nasal sprays really play no role in the management of CRS. You'll still see them used, they're promoted still by many doctors, but there's no indication for any nasal spray for chronic sinus disease in Australia from a TGA perspective, and they don't play a role in significant CRS in my practice. And to me, a little bit, when I hear someone talk about controlling CRS with oral medication and getting it under control, and then they put them on a nasal spray, it's a bit like hearing an asthma doctor say, I controlled the asthma, then I put them on a mouth rinse or a throat gargle. It's simply not delivering the medication to where it's required. So effective topical sinus therapy is a combination. It's not about using an irrigation bottle. It's not about having big sinus surgery. It's the combination of the two. Now, where's the EBM for this approach? This is an older study that Ray and I did where we looked at people who'd failed medical therapy who had this type of disease, non-isolated osteal obstruction. This is another problem in studies. They combine these patients, but really just this prior patient with patchy disease is who we included, and we didn't take people with systemic conditions. We gave them all a steroid irrigation sinus surgery, and we delivered the corticosteroid in this approach here, where we put the corticosteroid into the irrigation bottle, and we had the patients then deliver that into their sinuses. It's a way in which you're delivering it locally and avoiding systemic primary outcome here was not 22 and endoscopic scores. We had 111 patients over a year. And we showed here that at least in the symptom scores, the eosinophilic group did the best in terms of symptom management from this approach. And likewise, from an endoscopic score, the eosinophilic group did the best. Now, you might criticize this and say, well, maybe the non-eosinophilic patients we need to manage slightly differently. It's true. But the eosinophilic patients, which make up the bulk of chronic sinus disease, did extremely well. Now, a big question I have then is that patients say, well, I gave my patient a steroid irrigation, it didn't work. Well, if your sinus cavity looks like this, it's probably not going to work. You have to get the patients to heal like this for your treatment to work. And in the post-op period, it requires proper care, because it's not about just simply putting them on a local corticosteroid treatment. Patients need a lot of systemic corticosteroid initially because they have an inflammatory disorder, and there's an enormous inflammatory response from surgery, and it's only about between 3 weeks and 3 months that we transition them onto a local topical treatment only. And the goal here is to get a good response long term, where at 12 months they are simply using just a simple local therapy to manage their condition. Now, what are the cofactors here? It's not a big hole, small hole debate. It's about creating a single functional cavity. You've got to use a high volume because you need at least 100 mils to fill the nasal cavity and then get into the sinuses, because the sinuses are a dead ventilatory space. You need positive pressure, and in my mind, at least with this approach for people who are having corticosteroid, if they do have eosinophilic disease and you don't yet have a biopsy, the way of picking these patients out is that they usually have had a response from systemic steroids. So these are the patients that say, I had a great response from when I take oral corticosteroids, but they aren't able to be controlled in between. Well, those patients make great patients to offer a local corticosteroid treatment. So when do we operate? There's lots of different times when we just simply provide surgery. For AFS, direct to surgery. Severe polyps, grade 3 polyps, direct to surgery. Fungal ball, direct to surgery. This person here with osteal occlusion, my practice, I'm pretty aggressive medically. I give these patients cold-directed antibiotics, corticosteroids. I really try to reverse the process that's happening now before I decide to operate. But it's this patient here with the patchy mucosal disease that I think our specialty has struggled to really define on how we operate, when do we operate. This patient actually, in my opinion, is most common. This patient just represents someone with inflammatory changes in their airway. And in Australia, that's 9% of the population. So, you could easily walk away from my talk and think that Richard said that to get treatment into the sinuses, you have to operate. You simply got to operate on everyone. That's not the case. Patients who have patchy inflammatory changes in the airway, often if they're just getting a bit of mucus, just like an asthmatic gets a bit of a cough and they don't require much other than just doing some exercise and staying in shape. Well, the same is true for the nose. We see patients just get a little bit of mucus production, a little bit of congestion, and just using a saline irrigation may be all they require. This is like the mild asthmatic. But then we go to this step here where you see patients who easily get infections. This is like the patient who's an asthmatic, who every time they get a cold, they get a chest infection, much worse than everyone else, and get all wheezy, but are really pretty well in between. So it's hard to convince them to take a regular medication. This is the same for the sinus patients who maybe have a bit of mild sinus inflammation always, but are very essentially asymptomatic. And these patients then, whenever they get viruses and colds, they do poorly, and they occasionally need antibiotics to treat infective exacerbations. And you could consider giving them steroid sprays just to relieve congestion, but that's of little use. This is when we start to see patients who have significant burden of inflammation. These patients keep flaring up throughout the year, and we give them short courses of oral corticosteroid and antibiotics. What we're doing is reducing the infective flare-ups and reducing the inflammatory burden or inflammatory load. And you can do this for 2 or 3 weeks at a time, 2 or 3 times a year. Now that's the threshold for me in which, if you're treating someone with systemic corticosteroids and antibiotics this frequently, this is when you need to talk to them about having sinus surgery to shift the way they're managing their condition away from episodic systemic therapy to a local treatment. But you've got to have a patient who's engaged with the idea of using a local treatment, just like you have to have an asthmatic patient who's engaged with the idea of using a preventative inhaler. They have to be engaged in it, and the whole goal here is to give much tighter control of their condition and reduce their systemic needs. And of course, especially when it comes to polyps, this statement's very true. If prednisone didn't have any side effects, we wouldn't have jobs. And I'd like to thank you very much for listening to my talk, and my apologies again that I'm not there in person. Thank you very much.